CDC news article just over a month ago on March 21st, 2024. That's drawing our attention to an old disease that's slowly creeping into our consciousness again. In fact, for anyone who's been following the news or public health over the last year, there's been kind of a slew of increasing concern about the rising number of measles cases in Canada as well as around the world. However, I'm sure for a lot of us, this isn't something that we've had to think about up until recently, or maybe not even up until this talk. So really this begs the question, why is measles all over the news again? Despite our improvements in education, vaccinations, and preventative care, is this something that we should even worry about here in 2024, or is this just all fear-mongering and clickbait from news and social media? So for those that don't know me, my name is Kevin. I'm one of the fourth-year emergency medicine residents at the University of Ottawa. Welcome to my grand rounds on measles in 2024. Over the next hour, I want to enlighten us all on the current state of measles in Canada and how the outlook appears for the future. My supervisor for this talk is Dr. Gina Netto, one of the pediatric emergency medicine staff physicians. My objectives of this talk is to more than just go through a diagnosis of a disease that all of us have kind of gone through teaching for at one point or another. But I want us to have a fuller understanding from a public health perspective of what brought us to this point and where we should go in the future. Firstly, I want to discuss the measles cases in Canada right now and put into perspective of why we should have at least some concern about the recent trends and the dangers that it poses. Secondly, as a disease that we likely haven't had to keep in our differential very much, I do want to go through a brief overview of the presentation as well as the complications that it can pose so that we can be better equipped to recognize it in the emergency department if it walks through our doors. Third, I want to discuss how this disease highlights even more the importance of vaccinations in light of our current times and how we can help educate our patients. Lastly, I'm going to go over our current recommendations from our TOH algorithms as well as our infectious disease colleagues on testing, management, and additional care. So I promise this is going to be the only slide on virology I have, but measles is, at its basics, a viral illness. It's a morbillivirus in the Paramyxoviridae family, and it falls under a large group of febrile rash illnesses and is highly contagious. Thankfully, humans are the only known reservoir for the disease. So historically, it's made it a great target for eradication through vaccinations. But what's unique about measles is that it was and still is one of the deadliest diseases in the world. Before vaccines were invented, major measles epidemics around the world occurred every 2 or 3 years. And estimates across different sources approximate around 2 million deaths per year attributed to measles alone. During this time, it was estimated that about 95% of the population would have had exposures to measles by the age of 15. As you can see from the chart on the slide there, over the last 30 years, it's still a significant amount of mortality due to measles around the world, but it's been drastically improving due to ongoing efforts for eradication, especially in the developing world. In Canada, we can see that the rates, again, were quite high in the early half of the century, but there was a massive drop in rates following the introduction of measles vaccines in 1963. And then following that, there were even further drops after routine immunization for this was incorporated into our vaccination schedule. In fact, due to concerted efforts, we were able to achieve measles elimination status since 1998, according to the Public Health Agency of Canada. And this is even earlier compared to our US neighbors in the South, who was able to achieve the status in the year 2000. Now, realistically, this doesn't mean that we've eradicated all cases of measles in Canada, but it means that there hadn't been any endemic transmission of the disease in our region for at least 12 months prior to this. More recently, though, the trend has taken a bit of a turn worldwide. So according to data from the WHO, unfortunately, there's been a 30-fold rise in measles cases in 2023 in Europe alone compared to previous years. In Canada, this trend has also been noted. So this is the latest data from Public Health Ontario that's been keeping track of measles cases. So over the last 10 years, so from 2013 to 2023, we had 101 cases of confirmed measles. And then just in this year alone, so this is data up until April 24th, so the last report that I ran before giving this talk, we've recorded 14 cases so far. So that's 1.5 times the annual average in a third of the time. Diving into these cases a little bit further, we see that almost all of these cases, so the chart on the bottom right, almost all of these cases have been imported from travel. And then the vast majority, as you can see on the top left, are in incompletely immunized or people who have incomplete vaccination records. Looking at overall in Canada, this is from the government of Canada, there's been 65 cases of measles to date, according to Public Health. So you might be thinking to yourself, the absolute number of cases is still relatively low, and all of these cases are coming from outside of Canada. So why are we concerned about this? So I want to tell you guys a story about a relatively recent case that's close to home. So in 2011, Quebec suffered one of the largest measles outbreaks in North America. At the time, there were clusters of outbreaks happening in Europe and around the world, and approximately 21 cases were imported into Quebec, so mostly in the Mauricie region area between Montreal and Quebec City. Although initially the numbers were small, this quickly became a case study in how badly measles can spread through a population. So I want to go into depth about one case. So there was a man in his 30s who worked in a high school. He had just returned from a nice Caribbean holiday, and according to tracking, he wasn't aware he was symptomatic at the time. He spent several hours at the Montreal airport and then went home and then went back to work over the next few days. So you might see where this is headed, but he was unfortunately the index case responsible for causing an additional 678 cases during this outbreak. So why is measles so transmissible? Well, for one, it's an airborne disease, so it can spread through both respiratory droplets as well as contact. And in fact, it can linger for up to 2 hours in the air after a symptomatic person has already left the room. The disease has an attack rate of 90%, so meaning that 90% of susceptible people without the disease is going to develop it after coming into contact with a positive case. So just imagine, one person with measles on a busy Toronto subway, and how many people are going to be on that subway car in the next 2 hours. So to put this into more familiar terms, after the COVID pandemic, I think a lot of us became acquainted with the term R0. So for those that don't know, it's on average the number of people that a single infected person can transmit a disease to. COVID, a disease that threw the world into a bit of a chaos and still having lingering medical and political consequences to this day, has an R0 of 2 to 2.5. And with the most infectious variant quoted going up to about 5.5, depending on the source that you go through. Compared to that, measles has an R0 of 17. So it's one of the, or if not the most infectious disease that we've encountered in the world. So with that in mind, prompt recognition is going to be paramount to catching these cases and to prevent further disease transmission. So unfortunately, measles is pretty nonspecific at times and has overlapping features with a lot of other infections. But I want to impart with you all the 3 key features we should think about to consider this diagnosis in patients that you might see in urgent care. So firstly, there should be a fever. So at some point, a documented temperature above 38.3. Patients should have at least one of those classic C symptoms that we learn about in medical school. So cough, coryza, conjunctivitis. And as well, patients should have the maculopapular rash that really exemplifies the disease. The classic presentation of measles can be split up into essentially 4 stages. So incubation, prodrome, exanthem, and recovery. In the incubation stage, patients are asymptomatic, and it takes about 10 to 14 days from the time of exposure of a positive patient to exhibiting the first symptoms. The virus typically enters via mucous membranes and begins to replicate in the lymphatic tissue. And eventually it's disseminated throughout the body via viremia to exert systemic effects. In the prodromal stage, this is when the symptoms start to occur. And it should be approximately 48 hours or 2 days before any rash appears. It usually starts with very nonspecific viral symptoms, so things like fever, malaise, anorexia. And then shortly after that, again, those classic 3C symptoms start to pop up during this stage. In addition, this is the time that the Koplik spots that you guys probably heard of should start to appear as well. And this usually happens in the mucous membrane in the inner cheek and looks like little white spots on red erythematous bases, which what you can see on the right there. This is pathognomonic for measles, but again, doesn't have to occur in all cases. In the exanthem stage, 2 to 4 days after the onset of the prodrome, this is when you start to see that classic maculopapular rash, or so-called morbilliform rash, which is actually coined secondary to the measles virus. The rash typically happens first in the head and then spreads down to the rest of the body, but actually doesn't have to obey this pattern for all cases. Other features that can be noted at this point include lymphadenopathy, a high fever, and then respiratory symptoms like a pharyngitis. Lastly comes the recovery phase. So symptomatic improvement usually starts to happen about 48 hours after the onset, and full recovery typically occurs by a week or 7 to 10 days. There might be a post-viral cough that persists for a week or two, but keep in mind at this point, if there's any fever beyond 3 or 4 days, really think about potential complications, something that we'll talk a little bit more about later in the talk. Like with any disease, this can present on the spectrum with patients at risk for higher severity with some of these vulnerable populations. So specifically, in younger children under the age of 5, pregnant patients who are vitamin A deficient, something that we'll touch on a little bit later, and patients who are immunocompromised. So putting this all together, looking at the bottom, that's the typical timeline of the measles infection. But if you draw your attention to the middle top part of that graph, that there's 9 days in the middle where people are thought to be infectious or the most contagious. So that's 4 days before the rash appears, the day of the rash, and then 4 days after the rash appears. And so unfortunately, people can definitely spread this without having the classic presentation initially. And just to mention it briefly, there is the possibility of an atypical infection through modified measles, but these are typically more rare and usually happens in individuals with some pre-existing but non-protective immunity. So typically, neonates or newborns who have some transplacental immunity, people who got immunoglobulins, people who are incompletely vaccinated, and then people who've had measles before and coming in with a reinfection. So given that the presentation of measles can be really broad, especially in that prodromal stage, and features are overlapping and nonspecific, who do we actually have to test? Because if we're suspecting measles in everyone, and we're sending testing for everyone, theoretically, everyone's going to need an airborne room, everyone's going to need a negative pressure room, and I'm sure we're going to be getting even more occupancy pressure emails. So we really need clear guidance on when this is really indicated and who we should really be suspicious for. So I'm sure there's people out there thinking that, why do we have to worry about this at TOH? This is a childhood disease, and when should we actually suspect it in our adult population? But this is a demographic statistics for the positive cases we've had in this past year, so from January to April. And if you draw your attention to the bottom there, so 42% of the positive cases this year has been in people over the age of 20, so in our adult population that we would otherwise see here. Especially when you consider our population where we have so many immunocompromised patients with cancer, comorbidities, and immigrant populations that we have unclear vaccination status on, it's important to keep this part in mind. So I went through our TOH algorithms, and I had a chat with Dr. Sandy Wang. She's a friend of mine and one of the infectious disease fellows here at the Ottawa Hospital. And she actually says that they've been receiving a lot more calls from emergency departments as well as family physicians in the community regarding who to be worried about and who to test. So after going through the TOH algorithm as well as speaking to her, essentially there needs to be three things that's true to send for testing. So the first thing is there needs to be a compatible clinical syndrome. So having a fever, having at least one of those 3C symptoms. You don't have to have all three, but as well as having that classic rash. Secondly, it needs to be a susceptible patient. So someone who is unvaccinated, incompletely vaccinated, or just don't know what their vaccination status, or they're immunocompromised regardless of their vaccination status. The point being that right now we have such an effective vaccine that if they are vaccinated, it should be quite unlikely. And lastly, just given the close tracking of cases we have in Canada right now, there needs to be an epidemiological link. So a potential contact of some sort. So either they recently traveled in the last 2 weeks, they reside in an area where measles was recently identified. So right now that's in Montreal and Toronto, but again, it's because we've had very minimal cases in Ottawa so far, or they've had a contact with a measles case. And again, Dr. Wang does note that this is in the caveat that in the Ottawa region specifically, so unlike Toronto and Montreal, we've had relatively low number of cases, so this might need to be amended if cases start to rise here. So once we've identified a patient that we suspect has measles and requires testing, there's 4 samples that could potentially be sent. 3 of them are PCR, so MP swab, throat swab, or a urine sample, and then 1 is serology for IgG and IgM. In the TOH algorithm right now, it needs to be 3, so either of the MP or the throat swab for PCR, it needs to be a urine, and then it needs to have the serology for blood work. As far as diagnosis goes, this probably won't come to us because especially the cultures are going to take a few days to come back. But to make a positive diagnosis of measles on testing, there needs to be a positive serology for IgM or a significant rise in IgG, or there needs to be a positive measles virus culture or viral DNA. This slide is mostly just for reference. This comes from, I tried to clean it up a little bit from the public health website, but just to say that there are case definitions for a diagnosis of measles. But again, we're probably not going to be the one actually dealing with this, so just so that we know that this exists and we know where to look for it. Now, the diagnosis of measles is one thing. For the most part, it's going to be a viral infection. We counter these on a daily basis. But the reason that we're truly concerned is due to the complications. So I think it's important for us to have an understanding of what the consequences are, and as well recognize it if that's what brings people to the hospital for the first time. So unfortunately, the one concern about measles complications is that it's just quite common, more than your average viral infection. So 30% of patients with measles is going to have complications of some sort. Now, most of these are going to be very mild complication, but there's still a not insignificant amount of mortality and morbidity, especially when you take the world population into account. Again, keeping in mind the select population that we see at TOH as a tertiary hospital, the groups that typically are at risk include pregnant women, which increases both maternal and fetal complications, as well as those who are immunocompromised, such as cancer immunosuppressing medication. In emergency medicine, we like to split up our differential into the common and the dangerous. In measles, the most common complications are going to be essentially superimposed infections of some sort. An acute otitis media, GI symptoms including gastroappendicitis, lymphadenitis, as well as pulmonary infections, so things like bronchopneumonia, croup, and bronchitis. Notably, pulmonary complications is the most common cause of death due to measles worldwide and accounts for approximately 6% of that. In terms of dangerous causes, the most concerning complications are neurologic complications. So measles encephalitis can be the first presentation of this, and it occurs in approximately 1 in 1,000 patients and usually happens within days, so in the first little period. Patients can present with anything from your typical encephalitis picture, so fever, headache, neck stiffness, to something non-specific, like looking like a febrile seizure or just altered level of consciousness. These patients will typically be admitted and have further workup, but if we happen to do an LP in the emergency department, it typically will have a viral-looking picture, as you can see there. Unfortunately, this carries a really high morbidity, so 25% of these patients are going to have neurodevelopmental sequelae of some sort, and there's a 15% mortality for people who present like this. Similarly, acute disseminated encephalomyelitis, or ADEM, also happens in 1 in 1,000, and it's a post-infectious autoimmune condition that typically happens within 2 weeks and also has a high mortality. Subacute sclerosing panencephalitis, or SSPE, is the most devastating complications for measles. It's relatively rare at 1 in 10,000, but can occur up to 10 years after an infection has occurred. And it's a progressive CNS degenerative disease that has persistent deficits. So the last two are probably not something we're going to be worrying too much, but just it's there so that we're aware that these are kind of devastating consequences of measles. But it's important to keep that in mind. So just putting this all together, this is just a select list of potential infections and when we can expect to see them during the disease and how often they can recur, or when they recur, sorry. So what can we do to prevent these terrible complications? Over the last 60 years, campaigns for vaccinations is the single most important reason that we've been able to decrease the rate of measles around the world. According to the WHO, the measles vaccine has been one of the most cost-effective public health interventions worldwide. It's highly effective, so it reaches 85% efficiency after just 1 dose and 95% efficiency after a full 2 doses. And that's kind of on the, there's a range, and that's actually on the lower end of the efficiency. It goes up to as high as 98, 99%. Again, as you can see from the chart I showed before, the introduction of that vaccine in 1963 is correlated to the biggest drop with measles rates that we've had. In Canada, we have multiple forms of the vaccine. They're all in combination, so the MMR or the MMRV. So combination with mumps, rubella, and sometimes varicella. These only exist as live attenuated vaccines right now. Initially, when these were brought to market, there were also an inactivated vaccine that was created, but unfortunately had to be withdrawn because children were developing more severe atypical forms of measles after the infection because it was sensitizing them without true immunity. Currently, the measles vaccine is a part of our routine immunization schedule, with the first dose at 12 months and the second sometime between 4 to 6 years old. So keep in mind that for children, it's not until at least 4 years of age that they're going to be fully immunized for measles. Now, you might wonder why we don't vaccinate our children earlier. So previous studies have shown that earlier vaccinations, unfortunately, fail to induce seroconversion, especially below 6 months. And this is due to a combination of an immature immune system as well as still circulating amounts of maternal antibodies. As you can see on the screen here, this is a study by Loughlin et al. That does show that potential immunization at 9 months could confer good immunity, but they do find that later down the line there might be lower antibody titers as an adult. There are parts of the world where the measles vaccines do happen at a younger age, and it's according to WHO recommendations. But usually these are in more measles endemic areas where there's a higher risk of contracting measles and higher rates of complications. So it is really balancing the risk of contracting measles versus a potentially lower immunity later on in life. Because measles vaccine is a live attenuated vaccine, there are considerations to who can and can receive it. So unfortunately, it overlaps with our higher risk populations. So specifically, pregnant patients can't receive the vaccine due to a theoretical risk of teratogenicity, although there's not really clear evidence, as understandably there's no studies looking at it. But it is noted that if a woman inadvertently is vaccinated while pregnant, it's not an immediate cause for concern or termination. It just needs to be monitored. In the immunocompromised population, unfortunately, there is a risk of transiently enhanced replication of the vaccine, and just due to the nature of it being a live attenuated vaccine. So another hot topic during COVID was the idea of herd immunity. And like we mentioned, unfortunately, there's always going to be a portion of the population that can't receive that vaccine for one reason or another. And to protect both them and the rest of the population from spread, a critical threshold of vaccinations is required for herd immunity. So because of how contagious measles is, a population vaccination rate of 95% is required to achieve herd immunity. So unfortunately, despite an effective vaccine as well as efforts around the world, we're still falling short of this goal. So in Canada, we've been below this target for quite some time. Even before COVID, vaccination rates unfortunately dropped from 2017 to 2019. And then after 2021, so unfortunately peak COVID, this dropped even more, mostly due to a lack of access to primary care. The data is from Public Health Agency of Canada. It was only last collected in 2021. And with lingering effects of COVID, still lack of access to primary care, there is some concern that this number might be even lower. So, a bit of a trigger warning. We're going to briefly touch on vaccine hesitancy. I hope that everyone in this room is pretty much united in understanding that vaccines are a good thing, but it's a good idea for us to try to understand where the other side's coming from and maybe what we can do to try to shift their perspective. I think all of us at some point or another during COVID has interacted with someone that got agitated or been quite vocal about vaccination after you ask them if they've been vaccinated. So most of us probably avoid these conversations, myself included, but it's important for us to see who might be in that contemplative stage and might be open to change, similar to when we try to have these conversations with people coming in with drug and alcohol complications that we are considering to refer to RAMIC. So this is a survey performed in 2021 by the Government of Canada, and they specifically asked children of unvaccinated parents of unvaccinated 2-year-olds why they decided not to vaccinate their children. So this is the result and the 3 most common reasons cited. You can see there. So there's 55% of these people are concerned about vaccine side effects. 42% didn't think vaccines were necessary, and 26% just weren't confident in their effectiveness. So this concern about side effects have always remained consistently high across kind of multiple sources and surveys I looked at. And I wonder if it's correlated, unfortunately, to the infamously retracted paper published in Lancet in 1998 by Andrew Wakefield that falsely linked the MMR vaccine to neurodevelopmental disorders, so specifically autism. So over the next little bit, hopefully I can give you guys some information to try to combat each of these concerns. So there are side effects to vaccinations like with any treatment. So it's important for us to be honest and have discussions with patients if they have any questions. As far as immediate side effects go, patients might have a febrile reaction, and in children this can actually precipitate febrile seizures. But again, we've all understand that febrile seizures can be quite harmless and might need a conversation with parents. There might be an associated local discomfort at the site of injection, and there might be an anaphylactoid reaction. True anaphylaxis is pretty rare and typically due to components and preservatives in the vaccine and not to the vaccine itself. Excuse me. And for anyone who's curious, there is no egg components in the vaccine, so people with egg allergies can definitely receive this. When we dive into the statistics of the side effects of the vaccine and the complication of measles itself, we can actually directly compare the two, especially since the vaccine is a live attenuated vaccine, so a lot of the reactions are going to be very similar. If you look on your left there, if we have 100 children under the age of 5 with measles, thankfully a lot of them are going to have very mild viral symptoms highlighted in green, so things like fever, cough, runny nose. Similarly, in the vaccinated group, most are going to have very mild reactions, so the vast majority of patients. But we can see that for a decent proportion, or 26 of those children with measles, they're going to have more moderate severity symptoms, so things like GI symptoms and diarrhea that might need IV hydration, or an acute otitis media that needs antibiotics. Whereas when you look at the vaccinated group, 14 might have moderate symptom burden, and these are typically more self-resolving ones. So things like a high fever, irritability, lymphadenopathy, or a non-infectious rash that's quite bothersome. The real difference comes in the more serious complications. So highlighted in red there, unfortunately, 15 of those 100 children with measles is going to have serious symptoms, including pneumonia, which, as I mentioned, is a leading cause of mortality worldwide. Whereas compared to the vaccine group, it wouldn't even record a blip on that 100 with how low the rates are. Looking at the more rare complications, this is even more of a difference, to the point where it's almost non-existent in the vaccine group. So looking at things like encephalitis, thrombocytopenia, SSPE, it's a huge difference between the two. Now, I don't expect anyone to remember these numbers or quote them, but I just hope that this helps to drive home how big of a magnitude the differences between the two are. So moving on to management a little bit. So what do we do with the patients who come in with measles? So recently in March, we were sent this document by Dr. Hebert outlining the current algorithm on the management of potential measles cases. So it's available on SharePoint, so I won't go through all of it step by step, but I just wanted to highlight certain aspects as well as add in a few things that might be important to us as specialists in emergency medicine. So the number one thing to remember to prevent further cases is public health guidance. So remember that measles is a public health reportable disease, so more so than a lot of other illnesses that might require admission and other teams involved. Most of these patients are going to be discharged from the emergency department, so it's our job to keep public health and the general public informed. All patients who have or are suspected to have measles need to self-isolate. So this is a conversation we're probably all familiar with after COVID. But for patients who are awaiting testing, they need to isolate until the results are negative. And for those who do end up being testing positive, they need to be counseled to isolate for the period of infectivity, which is, again, those 9 days. So 4 days before the rash appears, as well as the 4 days after the appearance of the rash. Specifically for immunocompromised patients, they need to isolate for the whole duration of illness just because they're so susceptible. Most patients are going to simply require supportive care, but keep in mind that complication rates are high, so being vigilant to look for complications and treat them, things like acute otitis media and pneumonia. But are there any specific treatments that we can use in measles? So literature does talk about vitamin A as a potential treatment of measles, since there's many theoretical benefits. So vitamin A deficiency is associated with adverse effects of measles, as well as measles itself can actually precipitate vitamin A deficiency. So in literature, that line should say vitamin A deficiency effects, not vitamin A effects. In literature, it's been shown to delay recovery, have higher morbidity from blindness, and higher mortality from measles-associated complications. In fact, the position paper on measles put out by the WHO in 2017 recommends a course of 2 days of vitamin A to all patients who are diagnosed with the disease, regardless of when they present the care and what their severity is. So this is a recommendation that was news to me as I was preparing this talk and studying for the exam. So I wanted to look at where the evidence for this came from. So one of the first large RCT studies was from South Africa in 1990 by Hussey et al. This was published in the New England Journal of Medicine. They looked at 189 children hospitalized due to measles complications and randomized them to either vitamin A or placebo for treatment. And there was 92 and 97 children in each group, respectively. They looked at mortality as well as, so their main outcomes were mortality, and they also looked at morbidity with severity and duration of illness as well. They found that the patients receiving vitamin A had significantly more rapid recovery from complications. But more importantly, out of the, unfortunately, 12 children that died during this study, 10 of them were in the placebo group and only 2 were in the vitamin A group. So the recommendation that they made after this study was to give vitamin A for everyone. So there's a couple caveats with this study. They did find that at baseline, the population they had low retinol levels across the board. And all of the patients they looked at were patients who were being admitted for complications. So I tried to look for some more contemporary evidence. There's been 2 Cochrane reviews in the last 10 to 15 years on vitamin A and measles. In the top left there, Bello et al. Looked at the relationship of vitamin A to morbidity due to blindness, and they actually found no evidence. At the bottom, Yang et al. In 2011 looked at the effects in preventing mortality and serious complications. They ended up having a sample of 2,000, just over 2,500 patients, and across 8 trials. And they actually did find that 2 doses of vitamin A reduced pneumonia-specific mortality in children with a relative risk of 0.57. But otherwise, they weren't able to find other differences in other outcomes. So there's a bit more variation in recommendations when you look. So the CDC from the US is a bit more nuanced and suggests vitamin A as a treatment, but only suggest it for severe diseases or hospitalization. So I had a chat with Dr. Wang, our infectious disease fellow, about this as well. And she says that their group's recommendation fall in line more with the CDC recommendation. So the reason being that the WHO is taking a look at a more global population that includes more measles endemic areas, as well as areas that have higher baseline mortality and morbidity rates due to complications, as well as developing countries that might have higher rates of baseline vitamin A deficiency. Whereas in resource-rich settings like the US and Canada here, there's less of a consideration. So she suggests that vitamin A is only really necessary for patients with severe disease requiring admission or complications. But she does say that if people choose to give it to everyone with measles, it wouldn't be incorrect according to the WHO recommendations. One last specific treatment I'll just mention is ribavirin. So through my research, it is an antiviral medication that can be used off-label, but unfortunately, there's not a whole lot of evidence for it. And the cases that's been described to use this has mostly been immunocompromised, in the ICU, vented, or those getting treatment for SSPE. So it's probably not something that we're not going to reach for in the emergency department, but just to be aware that's another entity that exists. So with the rising amount of cases in Canada, at some point we're going to run into potential exposures and people who are worried that they might have come into contact with the disease. I know I've at least seen at least a couple of patients who've asked me worrying about this. So it's important for us to know what we should do in these instances and who needs treatment. So the guideline recommendations currently are really to give post-exposure prophylaxis to high-risk patients. So patients who had an exposure to a positive case and someone who is susceptible. So again, someone who's not completely vaccinated, children who are less than 12 months, so wouldn't have had their vaccination series yet, or people who are immunocompromised. So most specifically, the severe immunodeficiencies and bone marrow transplant, but is a consideration for other immunocompromised states. So again, keeping in mind the general obstruf, the amount of cancer and immunocompromised patients we see, it is another consideration. Public Health Ontario currently has an algorithm on recommendations of what and who to give PEP, but I tried to clean it up a little bit and really distill it down to 4 different categories. So for most of the general population, the MMR vaccine itself is given as PEP, and this is within the first 72 hours or 3 days of the exposure. But past that, it loses its effectiveness in this. So IVIG is recommended as the treatment, and this can be given up to 6 days. Pregnant women, unfortunately, can't receive the MMR, so IVIG again is the recommendation. And for infants under 12 months as well, immunoglobulin is also a recommendation. Now, keeping in mind, IVIG is for post-exposure prophylaxis only and doesn't confer any immunity, so patients who are susceptible will still need the MMR in the future. Okay. And with that, that takes me to my take-home points. So I hope that over the course of the talk, I've imparted on you how dangerous measles can be, given its contagiousness and the needs to be aware of potential public health implications. I think, honestly, right now, we're not in a stage of panic yet for another pandemic, but it's important for us to have some level of understanding about the recent trends and have some level of concern. Clinically, because of the rising rates, we should start to think about measles in any patient that present with a fever, rash, and compatible symptoms. That should prompt us to ask a few more questions about it. And we should be testing in those who fit the clinical syndrome, have a possible link, and are susceptible. For the most part, management is supportive, but just given the high complication rate, keep in mind and look for them and think about indications for admission, antibiotics, and even vitamin A. And last but not least, promoting and encouraging vaccinations is the only way for us to get at the source of the issue. And hopefully I was able to give everyone here some ammo and knowledge to empower them to, you guys to talk to the patients who might be a bit more hesitant. I think, like it or not, at this point, we're probably the healthcare provider that most patients are going to end up seeing as their point of contact. Now, I do want to end off the talk on some optimism. So as I was going through data for the talk, this is again for the vaccine survey in 2021. The article notes that 20% of parents actually had their stance on vaccine changes due to COVID. So initially, that sounded quite concerning. But when you look at the breakdown in it, in fact, 17 or almost 18% of these people are actually more likely to vaccinate their children after COVID. So hopefully this will be a reflection in the next vaccine survey and make this talk a bit less relevant, but it's still something to keep in mind. All right. So with that, thanks to everyone who helped me with this talk. So Dr. Gina Netto, my supervisor, Dr. Sandy Wang, my infectious disease specialist, Dr. Costain, my faculty mentor who helped me bounce a few ideas for this talk, my wife, Dr. Catherine Sullivan, and the study squad for helping me through this year. All right, and here are my references, and I'll take any questions.